Hi, this is Elliot Fishman, and welcome to our latest talk. And this is going to be a one-parter. It's going to be misdiagnosis and earlier detection of pancreatic cancer. It's not really going to be an AI talk, but it's going to be kind of a transition talk, looking at a recent paper Satomi Kawamoto wrote on where misses occur, and looking at some of the ways we think we can do better. And I'll first start off about talking about pancreatic cancer. Recent article in Lancet. Current guidance for pancreatic cancer surveillance is restricted to high-risk individuals who have germline mutations that predispose to a lifetime of increased pancreatic risk. Matre, who's a pathologist, and Eric Topol made the point that when a pancreatic cyst is detected incidentally on abdominal imaging, some patients are put in the high-risk category, and currently high risk accounts for only about 20 to 25% of cases we look at. Their question, of course, comes down, what about the majority of patients with no risk factors who present at an advanced stage? And they make the point that what we're doing now, and some of the articles published on monitoring high risk, have been very good, but it's still a small percent of the patients. And what else can we do? Can we use AI? Can we use AI looking at electronic health records? Companies like Abridge are doing that now. What can we do? The article goes on to say also, it's important to emphasize that these are retrospective studies and really have not been evaluated in a true real-world setting. And this idea about finding patients at high risk is a challenge unless you know what the high risks are. Obviously, certain germlines are high risk, but that's a small percentage of the patients. Are there other things we could do? Liquid biopsy tools are coming along, and perhaps these can make a big difference, and so that's really where the hope will come in. The contribution of AI does not stop at initial EHR-based enrichment, but also the thing about AI, it's going to have to work at multiple levels. It's going to have to improve how we could do CT and MR for detecting small lesions. Remember, we say that a radiologist will miss 40% of lesions under 2 centimeters, and those are typically the low-grade lesions that if we pick up, we can do surgery. And remember, stage 1 disease has about a 70% survival. So the combination of things, surveillance of high-risk groups, can help in early diagnosis in a small percent of patients, but we need to also look at expand the population. Also, when you talk about AI, and the reason everyone's so excited, and we're so excited, because it's increased detection, it's also helping develop new immunotherapy options, developing vaccines, and so AI has the opportunity for both diagnosis and treatment and management. In a study that used a transformer AI model that incorporated data of EHRs over several years, an aggregate of nearly 28,000 cases of pancreatic cancer were analyzed and compared with 11 million patients who not developed this disease. The primary data set was from the Danish registry. The authors were able to define a group of people aged 50 and older who had a 30 to 60 times higher risk than the general population of being diagnosed with pancreatic cancer in the next year. One of the EHR codes that the model consistently identified as a feature predictive of incidental pancreatic cancer in the next 2 years was diabetes. And again, there's lots of work going on now, particularly in patients developing diabetes in their 50s, and all of a sudden you see them 2 years later with pancreatic cancer. So a lot of work is being done to see how much of a risk diabetes is and how carefully we should follow those patients. Matre and Topol go on to say a second independent study used AI to differentiate 35,000 patients who developed pancreatic cancer from 1.5 million who did not. The study identified 80 features from lab tests, EHR, symptoms, and coexisting conditions. Again, within the algorithm, some of the things were intuitive, such as age or diabetes, while others underscore how AI can identify patterns not readily discernible by human assessment. mean corpuscle hemoglobin concentration in red blood cells might be one example. So again, we're really thinking about AI. And we are working hard at Hopkins. We're funded by the Lustgarten Foundation. We're working closely with Microsoft. We're doing our best for early detection of pancreatic cancer. And we are very optimistic that this will come. But in the short term, even though we're doing work for the past 7 years with AI, it's not our routine practice. It'll take a few more years. And most people don't have AI or even thinking about AI. In this article by Satomi Kawamoto and Taha Ahmed and our group, it was a great title, Hidden in Plain Sight, Commonly Missed Early Signs of Pancreatic Cancer on CT. So we're going to look at what is it you can do now. Pancreatic cancer has a poor prognosis due to the advanced stage. Prior studies have demonstrated that pancreatic abnormalities may be detected on CT in up to 38% of cases, even 5 years before diagnosis. So in this article, what we did is look at the signs that were very helpful for early disease that are often missed and try to emphasize to everyone, look very carefully. So we looked at things, isoattenuating lesions were always a challenge, isolated duct dilatation and cutoff, focal pancreatic enhancement, focal pancreatic atrophy, pancreatitis with underlying PDAC, and vascular encasement. So we looked at all of the features, and again, thinking about these, and we've always emphasized them, changes in texture, changes in the duct, focal atrophy, anything that looks different, you need to be suspicious. And chronic pancreatitis, there is about a 5% overlap in patients who have chronic pancreatitis and develop pancreatic cancer. And chronic pancreatitis is often hard to evaluate with all the calcifications, but you got to look carefully. Calcifications sometimes become displaced or they disappear. And then you need to look carefully at the vessels. Now, of course, if you have vessel involvement, particularly SMA or celiac, it means the patient has advanced stage of disease, but still you can intervene earlier with chemotherapy and potentially make a patient who is unresectable at time 0 become resectable 6 to 9 months later. Now, surgical resection, which represents the sole avenue for curative treatment, is really at this point offered to at most 20%, and often it's closer to 10% of newly diagnosed patients. Again, our problem is not detection, it's early detection. Again, imaging will be critical, but we talk about AI to improve imaging. We talk about tumor markers. They're being developed, but they're nowhere near where they need to be. And so CT is the key factor. Through early imaging, features of pancreatic cancer can be subtle and challenging. Again, this idea of looking very carefully. Recent studies with CT-MR and EUS suggest that multifocal high-grade intraepithelial neoplasm, so-called PANNs without invasion, traditionally referred to as carcinoma in situ, may be seen as patchy parenchymal atrophy. So atrophy, particularly focal atrophy, can be very subtle, but it's an important finding. Conventional pancreatic cancer on CT typically appears as indistinct infiltrative focal mass with extensive surrounding desmoplastic reaction. But again, you want to pick up things before it's that extensive. So things we need to look for, challenging are isoattenuating lesions. They could reach 5%. Hyperattenuating lesions may also be seen on some of the later phase imaging. Obstruction and dilatation of the pancreatic duct and common duct, the so-called double duct sign, is present in 80% of tumors in the head, and dilatation of the main pancreatic duct is seen in about 50% of tumors of the body. Again, you got to look for the pancreatic duct. If you see it sometimes, higher resolution scans, you can see the duct, but the duct over 3 millimeters, you have to worry. And if you see a duct and it stops, you especially have to worry. We see many cases that the initial scan showed a mildly dilated duct with cutoff, and the radiologist wasn't concerned. When you see cutoff, you have to be concerned. If cutoff is early, you may not see pancreatic atrophy distally, but if the cutoff has been there for a while or it's a very sharp cutoff, there may be distal glandular atrophy. So look at all of those features. And here's just a couple of the images from the article. You can read the legends showing very nicely how lesions can become very, very subtle, easy to miss, and within a year, they're easy to see. But in retrospect, you can see in these cases, the lesions were present early on during the study. We talk about commonly missed signs of early PDAC on CT. And again, I'll just comment on them. This is a chart from that article. Small isoattenuation, adenocarcinoma without contour deformity. One of the most difficult signs to pick up. We think AI can do well there. Pancreatic duct dilatation and cutoff. You should not miss these. Focal pancreatic enhancement. You know, it enhances a lot. Then you're thinking about a neuroendocrine tumor, but sometimes it can enhance a little bit. A little too much enhancement or a little too little are worrisome. Atrophy is always worrisome. Acute idiopathic distal pancreatitis. If you have what looks like pancreatitis, yes, we have that challenge at times with autoimmune pancreatitis, particularly if a patient has no history of other reasons for pancreatitis. So it kind of can be challenging. You just need to follow the patient carefully. Chronic pancreatitis with underlying PDAC is always a problem. I mentioned that a few moments ago. And of course, very early vascular involvement. Now, it's not always going to be from cancer. We can see that with vasculitis, IG4, for example. We can see this with autoimmune pancreatitis. We can see it from other causes, from lymphoma to other malignancies. But again, you need to look carefully. If the vessels look abnormal, they're thickened, you got to suggest the possibility of neoplasm, maybe suggest vasculitis, but the patient needs to be worked up. There's no doubt about it. Now, we also speak, again, I mentioned about the pancreatic duct. 3 millimeters or greater or abrupt cutoff are the most classic signs for PDAC, but it's only in about 60% of cases at most. Though closely associated, the presence of ductal dilatation and duct cutoff are not specific, but can be caused by other pathologies, such as chronic pancreatitis. But again, you need to be evaluating these patients. What we see happen often is someone will just mention the duct or not mention it and won't suggest follow-up. You need to look very carefully. If I see a cutoff of the duct, Dr. Cameron always made the point, the duct is large, there's distal atrophy, that's a cancer, whether you see it or not. Some people will then go to EUS, you can go to MR, but it's not going to show anything different. So EUS with biopsy becomes critical. In the past, if you saw a duct with cutoff, you know it's a tumor there, people went directly to surgery. Focal main pancreatic duct changes may be seen in 13% of patients with PDAC 13 months before diagnosis is clinically established. And 13 months is a long time, and earlier diagnosis is in the patient's advantage. Again, we talked about focal atrophy, an article by Toshima as the most common noted CT abnormality on pre-diagnostic scans. Focal atrophy was present in 37.9% of pre-diagnostic CT at a duration of 4.6 years before diagnosis. In their hands, in their article, this was the best sign. So again, looking for focal atrophy, obviously with duct dilatation, it's so much easier, but that alone, you need to be worried. And they hypothesized why this might occur due to neoplastic cells, pancreatic drainage dysfunction. Whatever the reason is, atrophy, which can be due to things like chronic pancreatitis, can be due to prior trauma. We've been fooled there. But again, you need to work these patients up. We also know, of course, the overlap with pancreatitis. We mentioned that before. And there is an overlap of patients who develop cancer and pancreatitis. Pancreatitis may be the earliest sign of cancer. We talk about unusual pancreatitis, autoimmune pancreatitis, which is often confused with pancreatic cancer. We've seen patients go to surgery because it was felt that they had cancer and it was AIP. Now, the thing is, the CA19-9 can be elevated in autoimmune pancreatitis. Patients have weight loss, patients have abdominal pain, and it's often very challenging. Again, new onset diabetes or weight loss can occur more commonly in pancreatic cancer, but can occur also in pancreatitis. And again, there's a cumulative risk of pancreatic cancer of about 4% after 15 to 20 years of chronic pancreatitis. So we need to be much more careful in those patients. Look very, very carefully. I know it's hard on CT, but when I follow studies, I look at the calcifications. Maybe there's more, maybe there's less. When there's less, you need to worry. More, you don't need to worry. But maybe there's displacement. And so what I worry about is, could there be displacement of the calcification because there's a tumor developing? So it's very, very important to look carefully. Sometimes CT is not definitive. MR can be helpful. EUS can indeed be helpful. Another factor we talk about is vascular invasion. Now, in pancreatic cancer, the main reason patients are unresectable is because they have arterial or venous involvement. But again, not everything is pancreatic cancer when there's vascular involvement. I spoke about that a few moments ago. I've also spoken about that a few months ago and a few years ago. On imaging, circumferential perivascular soft tissue cuffing or stranding with associated loss of a fat plane is characteristic of vascular involvement. On CT, however, differentiation of true vascular invasion from perivascular stranding from inflammatory changes due to pancreatitis or vasculitis can be difficult. And it seems to me that we're seeing a lot more cases of vasculitis. Patients present with abdominal pain, and you're thinking pancreatic cancer may be one of the processes. And we've seen lots of cases, IG4 disease, one of the things we see very frequently now, Ernheim-Chester disease, we've seen cases of that. So not every patient with thickening along the vessels is going to have a malignancy, but all of them are going to have something and they will need to be worked up. Now, in pancreatic cancer, the majority of cases are in the pancreatic head, and then we talk about invasion of celiac and hepatic and SMA. And again, that becomes very important in terms of staging. We use 3D modeling to help us in that regard. The surgeons are more aggressive in terms of things you can do, like Appleby procedures or doing resection off the SMA, particularly with uncinate tumors after chemotherapy, if the patients respond well. Now, I will say that the hardest areas to look at really are the uncinate, where there's often very subtle tumors, but those are the ones that often have vascular involvement at an earlier time scale. So it's very important to look carefully at the vessels and look very carefully at the uncinate process. Again, if you only have tumor in the uncinate, you may not see duct dilatation. The earliest thing you may see is this vascular involvement. And here's just one of the cases from the article showing you subtle changes that were missed in the patient's pancreas by the body early on. There's a subtle tumor there, and only a few months later, which was about 6 months later, you can see now the extensive vascular involvement. So if you've gone with a patient who may have been resectable at presentation and 6 months later has extensive tumor infiltration, particularly around the celiac and the SMA. So when I think about misses or near misses, when I see the cases that come to a multidisciplinary conference and realize they had outside CT 6 to 12 months ago, and in retrospect, the tumors were there, the things I notice are size. No one's going to miss a 5-centimeter mass, but most people are going to miss a 1-centimeter mass. Location, tail of pancreas, and uncinate are the areas I see smaller tumors miss most commonly. Look carefully. We talked about density. Increased density, decreased density is more common. Any change in density, any change in the texture, any change with atrophy are all critical to making the diagnosis. Clinical history. Obviously, we talk about diabetes, we talk about weight loss. Diabetes is something that is being looked at very, very carefully, particularly in 50 and 60-year-olds. And the quality of the scan. If I ask you for a pancreatic protocol, you're doing arterial and venous and thin section. And so you're more likely to see the tumor. If you're just doing a run-of-the-mill pancreas as part of an abdominal CT where you're doing 3 to 5 millimeters, you may miss it. Also, you have no suspicion. Patient may have vague abdominal pain, or maybe the patient was getting a CT for trauma, or for kidney disease, for hematuria, stone disease. We need to look at every case as if it could be pancreatic cancer. Give an extra look at the pancreas. And of course, that's the reason why I think AI is going to be very strong, because it can look carefully at the pancreas on every single case. And I know we're all very busy, and so we don't routinely do that. So let me now show you a number of cases. We'll do this quickly just to go through them, of where the case is an example of a tumor that was missed initially. Here's an example. There's a subtle mass, textural change in the head of the pancreas. Not very tricky. It's under 2 centimeters. When you look carefully, it's a dilated pancreatic duct. There's atrophy of the gland. The patient had a dilated duct previously, which was not commented on. Now the tumor is more obvious. Now there's no vascular invasion. This patient will get chemotherapy and hopefully be resectable in a few months. But there's the tumor, under 2 cm near the uncinate. You got to pick that up. Another case, dilated pancreatic duct. There's a transition point. Yes, is there a mass here? You point to it, it sure is. There's textural change. But the key thing to me is the common duct and the pancreatic duct. There's no common duct dilatation because it's a body lesion. But look at the pancreatic duct. The pancreatic duct is dilated. There's atrophy of the distal body and tail of pancreas. There's a cutoff. Yes, you don't see a mass that's large, but you want to pick up a small mass. This patient is resectable at this time because there's a small mass present. And here's a few more views of that, showing you the arterial mapping as well. And here it is with cinematic rendering. We are using cinematic to look at textural change and pick up subtle lesions. I think textural change will be very, very important to us. Another case, atrophy of the body and tail of the pancreas with some duct dilatation. That's a bad sign. You see it here. There are several cystic lesions, IPMNs, and then you scan down to the head of the pancreas and there's a mass. But initially, all the patient had was the duct and the small IPMNs. But that alone is concerning. When I see IPMNs, I'm even more careful. We follow IPMNs. Of course, only about 3% of patients with IPMNs develop cancer over their lifetime. But you need to look even more careful because you're going to be following these patients for many years. But when you see the duct dilatation, you got to be thinking about a mixed type IPMN. And so you have to be worrying about cancer. And again, it's not so subtle anymore because there's the mass and the patient does have arterial involvement. And here it is on the 3D reconstructions with MIP and volume rendering. We look carefully at the vessels. We present these images to the surgeon as they plan operations. Another example, dilated pancreatic duct. Here's a subtle mass, but you can see the textural change. It's also mass-like, and you have the dilated duct, but this cutoff. Just the cutoff of the duct tells me pancreatic cancer. Then I look carefully, and there's a mass present. There was a study done about 9 months before that had the duct. It did not show a mass, but the duct looked very similar, and that patient would have been resectable. The patient still at this point is likely resectable. These days, almost everybody gets chemotherapy, so you'll get chemotherapy followed by surgery. You'll get a distal pancreatectomy, very nicely shown in this example. And again, the importance of the dilated duct, and then the tumor showing up very nicely. Another case, here's a patient where it looks almost like pancreatitis stranding by the head of the pancreas. But then if you look carefully, there's a mass in the uncinate. That mass is all of 1 centimeter. The rest of the gland, the body and tail look terrific, but it's this uncinate lesion. Remember, I told you one of the most common areas to miss tumors is in the uncinate. You don't have a dilated duct. You may not see vascular involvement, but these patients would be very resectable. Now, if you miss that lesion in the uncinate, the patient will have vascular invasion. So in this patient, there was no vascular invasion, replaced right hepatic off the SMA, nicely seen, and this patient will get a Whipple's procedure, and the patient is one of those who should be cured, hopefully. But again, this was 1.8 centimeters maximum dimension. You can see it's a different density than the fatty replaced pancreatic head. Very, very important. And again, the 3D mapping from the venous phase showing you the portal vein looks good, and other images would show you nicely the patient's SMV. So I've gone through a number of things. I've said to you that the future of pancreatic cancer is AI for detection, looking at EHR, finding risk factors, finding other causes, maybe diabetes, maybe other things, certain blood tests for looking at early detection of pancreatic cancer, and then, of course, helping us with early detection by being better at detecting smaller tumors on CT and MR. In the near term, we need to be the heroes. We need to be looking carefully at the CT. Think about the things I spoke about, the double duct sign, dilated pancreatic duct, atrophy, changes in texture, all of the things that allow us to do early detection. And again, think about the reasons people miss small tumors. They don't appreciate the pancreatic duct. They don't appreciate gland textural changes. Subtle masses in an area like the tail of pancreas or uncinate process are commonly missed because there's no duct dilatation. Vessels look good. And finally, look carefully at the vessels. Not everything that causes thickening around the mesenteric vessels is going to be cancer. I spoke about vasculitis, but you need to be investigating if you see that. And with that, I thank everybody for their attention. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.